Well, hello everyone. Welcome to our PPCL Echo. I'm Jody West. I'm the coordinator. Today, Dr. Olivier, who's usually our facilitator, is not able to join us, so we're going to rely on all of us to fill her shoes as best we can. So I know I've asked a little bit, but if everyone could go ahead and put their information in the chat, that's the best way for us to make sure you get the follow-up survey and get the slides to you follow. So if you do that for me. Today's agenda is always tight as it goes, and so we're going to do our best to stick to it. And I'm going to lead in a quick introduction to a hub team for everyone that's here, and then following that, Dr. Campbell is going to present on the didactic, and then Ashley is going to present the case, and we'll ask for clarifying questions and recommendations. And all of that information will be sent to the participants following the session. So I'm Jody West. I am the coordinator of the ECHO, but I'm also the program manager for the provider-to-provider consultation line. We are a no-cost provider-to-provider telephone or email consultation and education program. We focus on pediatric and perinatal mental health care providers. Pediatric and perinatal health care providers to address mental health concerns of their clients and their patients. This ECHO series is part of the educational services that PPCL provides. So there's some information. If you scan that QR code, then it will bring you to our website and how you can register for our program and some resources we have on there. It is a statewide no-cost consultation program, so we'd be happy to inform anyone of questions you may have, just to reach out to us, and we'll be happy to stay on as well after. Ashley Hutchins, if you want to introduce yourself, please, everyone.
Hello, my name is Ashley Hutchins. I am a psychiatric nurse practitioner at Bloom Mental Wellness in Lafayette, Louisiana.
Thank you, Ashley. Dr. Katie Queen. You're able to come up and
oh, hey guys, my camera I think is not on yet, but my name is Dr. Katie Queen, and I'm a general pediatrician and obesity board certified, and I work in a rural clinic in Bogalusa, Louisiana, and I'm part of the ECHO hub team.
Thank you. Lena and Sienna are also members of the PPCL team. They help us with all the behind the scenes coordination of everything. And then I don't see if Dr. Campbell has joined us yet.
Yeah, I'm on.
Oh, I'm sorry. I have multiple screens up. Thank you for joining us, Dr. Campbell. What we'll go ahead and do is we will proceed where you can present your information. I'll promote the slides for you. And just let me know when you're ready for us to move on.
All right. Hi, y'all. I'm Dr. Megan Campbell. I am a child psychiatrist. I'm a professor of psychiatry at LSU, Health Sciences Center in New Orleans, and I work at Children's Hospital of New Orleans as well. So today I'll be talking to you guys about aggression, managing pediatric aggression, which means a lot of different things and also very little, because it's so vague, right? Violence, of course, is a behavior and not a diagnosis. And actually, let me sidetrack real quick. Sometimes I have issues with my microphone. And so if y'all at any point in time quit being able to hear me very suddenly, just let me know. I won't stop talking. And so if I've gone silent, just say, let me know my mic is out. All right. So in terms of managing aggression in children, of course, this is a behavior and not its own diagnosis. And, in some instances, aggression can be a normative thing. For example, tantrums are still very common and normal through age 5, right? And my toddler might hit me, and that doesn't mean he's a sociopath, right? So when we're talking about aggression in children, and really any diagnosis for children, we need to put in a developmental lens on the picture. And I think, most of us are pretty familiar with that concept. But I think that a lot of times what we have to do is educate parents to that concept. You know, I have parents asking me all the time, my child talks to themselves during imaginary play. Does that mean they have schizophrenia? You know, so all kinds of questions come up when parents are concerned about their children. In terms of managing aggression, I think a big part of that, can we, next slide, is considering what do we think the problem is. First and foremost, I would say we have to assess developmental norms and the context of the situation and ask ourselves, well, is this just a normal process? Is this somebody, a 4-year-old who became angry and decided to use their physical body? In which case, maybe this is not any, pathological process. That also means assessing for comorbidities, assessing for their baseline function is hugely important. I can't make a diagnosis without knowing someone's baseline, right? And so that's really, really important for children, getting that developmental lens going on, understanding how they're doing in school and with peers and what the family dynamics and relationships are like. I can't assess violence without knowing all that stuff. So getting a really good psychosocial history is imperative. That being said, what kinds of things are we looking at? Well, here's a list of common diagnoses that do feature aggression or violence in them. And we've got intermittent explosive disorder, and we've got psychosis and mania, which may lead to impulsive violence, often due to, feelings of paranoia or anxiety. In general, of course, paranoia and anxiety in a non-psychotic person also veer someone towards an aggressive outburst. So it is not psychosis in and of itself that makes somebody violent, but often the symptoms of the psychosis that may make someone behave in a way that is seen as erratic. Mania, of course, people are more impulsive. Disruptive mood dysregulation disorder, DMDD, is new to the DSM-5. That diagnosis is for kids aged 6 through 18 and is characterized by severe tantrums or behavioral outbursts completely out of proportion to that anticipated by the stimulus. So, for example, I might be a 10-year-old who has a complete meltdown, throwing fists, turning over desks because we're out of milk, something that is not a typical stimulus. And in between outbursts, so having those outbursts at least 3 times a week for over at least 6 months and symptoms going back over a year. And in between outbursts, I'm in general a cranky, irritable disposition. My personality is such that people are walking on eggshells around me, and I've been that way for a long time. That's essentially what DMDD is in a nutshell. Those people often have aggressive outbursts. ODD, oppositional defiant disorder, conduct disorder, of course, violence and aggression is more common in conduct disorder. ADHD, there's a lot that goes into impulsivity. And people with aggressive outbursts or outbursts in general have high comorbidity with ADHD. Intellectual disabilities, the global developmental delay or autism, among others, fetal alcohol syndrome, hugely. These people are often have impulsivity issues and may have aggressive outbursts associated with their intellectual disability. So that's pretty common too. The personality disorders, borderline, dissocial and antisocial personality disorder, those are very similar. Dissocial is kind of an older term. And then of course there's violence against self, like parasuicidal behaviors. I have been in the presence of people who, adolescents who were so dead set on harming themselves that they were aggressive in to try and meet that goal to harm themselves. And then, of course, we also need to take into context what in the court of law they would say is non-pathological, and that's things like criminal behaviors, premeditated aggression, learned socialization. So if I'm really mad at my husband and I plot to murder him, or in a crime of passion, shoot him, then I probably don't necessarily have a psychiatric condition, but rather some criminal behavior. So of course that's always important. I think a lot of times in psychiatry, what we end up doing, and this is usually our older teenagers or adults, a lot of times we're ruling out the presence of psychopathology in order to get to that conclusion that this is a baseline learned behavior or criminal premeditated and not an acute mental illness. And therefore we're recommending, social or judicial means as opposed to psychiatric treatment. All right, next slide. So I know I've got more slides than I do time, so I'll go kind of quickly through some of these concepts. In aggression, oftentimes what we talk about the most is conduct disorder, because in conduct disorder, there's a frequency of pervasive violating the rights of others, and that may include aggression. So in conduct disorder, that's a repetitive and persistent pattern of behavior where the basic rights of others and societal norms are violated. And that is manifested by some of these other criteria. Next slide. So they've got the categories of conduct disorder: aggression to people and animals, destruction of property, deceitfulness or theft, serious violation of rules. And a lot of times this aggression, like rape, carjacking, mugging, breaking and entering, even just starting fights, physical fights using weapons. So how severe the conduct disorder depends on the number and level of severity of these kind of things. So you can have a mild, moderate, or severe conduct disorder. Next slide. Next slide. So what's the relationship with conduct disorder and other diagnosis? What are we thinking when we're trying to rule in and out conduct disorder? Well, we're relating conduct disorders to other similar diagnoses, and that might be ODD, oppositional defiant disorder. Some people see these as kind of a continuum versus a separate entity. I think of them as pretty different because in ODD, it's really about control, not wanting to be controlled. It's this oppositional and defiance towards authority. And in conduct disorder, you are violating the basic rights of others, and that may or may not be accompanied by an unemotional, callous disregard for other people's feelings or rights, but in general, there's a lot of vindictiveness and boundary pushing there. Although ODD kids are irritable and argue a lot and can be moody and blame others, so some of that arguing is there. It doesn't necessarily need to have overt aggression though. Next slide. Other relationships with other diagnoses, PTSD, a lot of people with aggression and conduct disorder have PTSD symptoms, and actually with a high frequency. Remembering that PTSD is not uncommon in even very young children. Unfortunately, you know, there's a lot of things kids get subjected to that falls in the category of traumatic experiences. People who go on to keep the symptoms of conduct disorder as an adult often are described as having antisocial personality disorder. The addition is that there is, with antisocial personality disorder, is that often there is that callousness and lack of remorse. And less than half of conduct disorder teenagers become antisocial adults. So a lot of them do improve with maturity and time. That being said, a lot of conduct disorder kids still do have some, you know, interpersonal challenges. ADHD, very high overlap as we talked. Thinking about that limbic system and that prefrontal cortex that's suffering, and with all the impulsivity that goes along with aggression. To me, I see a kid who's been traumatized, has PTSD, some anxiety, some ADHD, and bam, you know, they're not far from being reactive, getting into fights, being willing to throw down. Of course, substance abuse leads to increased rates of aggression and the anxiety disorders. So all of these things bear assessment. You gotta assess for all this stuff when you're trying to figure out how to treat the aggression. Next slide. As are the other diagnoses of autism spectrum disorders. Those are usually associated with tantrums and destructive behaviors. Depressive and bipolar disorders, look for the episodic periods of time. So if I was to say, oh, this is out of character for their norm, right? If I have a personality disorder or developmental disorder, it's not out of character. That's who I am. That's how I've always been. But a depressive disorder or an adjustment disorder is specific, you know, is episodic or specific to a reaction to a stressor, right? I think it's worth noting that of teenagers with conduct disorder, about a third also have reading retardation, which means reading retardation is defined as, I think it's at least 2 grade levels of reading below that expected for the age. So if I'm in 5th grade, I'm reading it below a 3rd grade level. That's not to say they have an intellectual disability, but there are corresponding aspects of our brain and neural development with reading comprehension and impulse control and modulating aggressive feelings. So I think that's a really interesting overlap of neural development. Next slide. For our very little ones, for our small children, these are toddlers and preschoolers, 3 to 5-year-olds with severe, frequent, intense tantrums, coupled with persistent, irritable, angry mood, causing an impairment in function to child and family. That's called disorder of dysregulated anger and aggression of early childhood. So this is sometimes a antecedent to the DMDD type of situation or ODD type of symptoms. And the domains are anger and temper tantrums, non-compliance and rule breaking, reactive aggression, so aggression when upset, like, no, you may not have candy for dinner, and proactive aggression, like I just came into the room and started hitting. And that's like starting fights, being coercive or manipulative. Next slide. Of course, like we've said before, let's always remember to keep in mind sociocultural impacts on behavior. And that may be subcultural deviance, right? I may be a well-adjusted individual, but in a deviant peer culture. I might have been socialized with, you know, gang violence, and maybe I have multiple family members who behave in a high expressed emotion household. Maybe domestic violence is common, maybe organized crime is common. And so this may be not a psychopathological process, but what I see as a social norm. All right, next slide. This will go through briefly. We'll just note that when you develop conduct disorder or severe aggressive problems less than 10 years old, you're more likely to have a greater pathology or greater severity, which means it's more likely to persist. It's correlated with other comorbidity problems like lower IQ, and often have worse adults. But conduct problems do often benefit from intervention, especially at a younger age. And even when they don't develop the antisocial personality disorder, they still have higher rates of maladjustment. And so it's worth intervening. It's worth trying. Next slide. Right, there's our sociocultural norm. I think it's worth recognizing that conduct disorder is extremely difficult to manage. So a lot of times as providers, what we have to do is check ourselves, our transference, our fears and reactions. They often, people with behavioral problems and aggression often are highly frustrating to work with. They may manipulate treatment. They can be embarrassing because they don't get better a lot of times. The parents are often angry with us. So a big part of this is also our reflection, our patients, our managing countertransference, our talking to peers about how it is that we're just handling cases like this and coping with them. Next slide. Yeah, next slide. All right, that's echoing that they often don't respond to regular treatment, and we may even have fears of safety. Or what's very frustrating is they can often interrupt otherwise successful treatments. So they may disrupt groups and classrooms. On an inpatient unit, they often blow apart milieus. And so there's different ways of treating that on an inpatient unit, but oftentimes we're just likely to get them off as soon as possible, which means less help for them. So whose problem is it? Do we medicalize it? Do we say it's a legal problem? Is it an educational problem? Is it a social problem or a parenting problem? And the answer is a lot of times it's really the intersection of all these things. And some treatment modalities are made to intersect, like FINS and psychiatric services in schools, therapeutic environments, GED programs in prisons. All these things are kind of hopefully gearing towards this intersection. Next slide. Next slide. Let's skip over etiology in the pursuit of timeliness. But essentially, I'll say this about etiology. Essentially, there's lots of risk factors. It could be genetic. It is often social or socialized. It is often exposure to violence and aggression. That could be domestic violence, or it could be punitive punishment paradigms, like just severe discipline, things like that. But what do? What's the course and prognosis? A lot of times this impacts other aspects of our functioning, right? If I'm an aggressive teenager, I'm not going to do well in school. I'm not going to have friends. I'm not likely to have a job. And so then I become more reliant on the system or my family and have a harder time becoming an independent functioning person. All right, next slide. All right, so here we go into treatment. What are treatment modalities? Well, there is no specific medication to treat a behavior. And so I think that bears recognition and really counseling towards parents. what are gold standards? We need the behavioral therapies on board. We need MST on board. And so if people aren't willing to do therapy, and a lot of times that means the parents doing parenting sessions, then the medicines will have limited benefit. You have to be really careful how you proceed here, because what is a challenge is we don't want to suggest that the parents are bad parents, or that it's their fault, or that they're to blame. And so you try to avoid that perception when you tell a parent, oh, well, you really have to do therapy, parenting therapy, you know? What I think helps is to talk about, you know, not all children get parented the same way. And a lot of times when we have kids with special needs, like aggression or developmental issues, we have to learn different tricks, parenting tricks, to help this specific child. And so sometimes you can get a parent on board with parenting therapy when you really talk about how it's boosting their skills as a parent. They need a lot of empathy. They need a lot of validation. And they need a lot of tools for their toolbox, because these parents are exhausted and frustrated, and so are the kids. They both get told all day long that they're doing the worst job ever and that everybody's terrible. You know, all these parents are getting told they're terrible parents, and all these kids are getting told they're terrible people. And their kids and parents are telling each other that, you know, and the school is telling them both that. So they're very frustrated, and they really need a lot of validation to get them on board with treatment, and to, you know, hopefully with each other. What meds do work? Oh, go back a little. These are the meds that work. Okay, so a lot of times stimulants and alpha agonists are what works the best. ADHD is super common, right? It also helps with impulsivity. So now stimulants do bear the side effect potential of increasing irritability. So in that regard, we want to monitor carefully that we're not making someone more irritability. That's especially true for people with developmental disabilities. But if it's not making them more anxious or more irritable, it can really be helpful. For my PTSD, ADHD kids, I like the combo of stimulants and alpha agonists. Antipsychotics are also very, very common, especially Risperdal and Abilify. Those are probably the most common neuroleptics to use in children. People also use beta blockers like propranolol, Inderal, mood stabilizers, lithium depakote, lamictal, carbamazepine, or oxcarbazepine. Those have, you know, for highly aggressive kids, either towards themselves or to others, lithium and depakote do okay. In general, the mood stabilizers aren't as effective for kids as they are for adults. And that becomes more true the younger the child. It's rare. I see a lot of very aggressive kids. I don't really put them on anti-epileptics much. Maybe for my older teenagers who really aren't responding to the combinations of stimulants, alpha agonists, and antipsychotics, then I consider it. Or if I have a highly aggressive psychotic kid, of course, then it's indicated, for its FDA indication. But mood stabilizers just don't work that well in kids. Benzos, not a great option. I mean, you do have to calm people down sometimes when you need to, but we don't, of course, that's a slippery slope. And antidepressants, don't forget to check for those comorbidities. If anxiety is driving the irritability or depression driving the irritability, you want to make sure and treat that. All right, next slide.
Well, Dr. Kimber, I think we're going to have to move forward. We're going to share these slides with the participants. So is it okay if I go forward past the
Sure.
study?
The Tosca study was a famous one that established the efficacy of Risperdal, but they only did that after they already started kids on the ADHD stimulant. So they took aggressive kids, put them on a stimulant. If they were all better, they left it as is. If they still had aggression, they added Risperdal. They started at 0.5 at night and went up in increments of 0.5 every week. I don't remember the max dose they got to. That might have been a mg per kg, or it might have been 3. So the answer is the Risperdal helped. 1 year later, it really didn't help that much. It does help some. So this study suggests optimize the ADHD treatment first, and then if you still get them in therapy, behavior therapy, and then if they're still not responding, then start a neuroleptic. Don't jump to the neuroleptic as first line. There's different studies in Europe that really say, please don't jump to the neuroleptic as first line. They recommend optimization of the mood stabilizers and the ADHD meds first. All right, next slide. So in general, pick an intervention, make sure it involves both therapy and med management, engage the family. They're all fearful about being judged and suspicious of treatment. Identify their strengths, treat comorbid conditions, and promote social and academic learning. So it's about promoting wellness and strengths. FFT and MST are good. The end. Oh yeah, bad treatment, scared straight doesn't work. All right,
Okay.
thanks so much, guys.
Well, we appreciate your time. We're going to ask for folks, we could either put comments in the chat, questions that, there is a question Dr. Leslie asked in the comment about opinion on guanfacine immediate release versus extended release for aggression.
I like it. I don't know if I have a large opinion on efficacy. If I have a kid who's highly aggressive throughout the day, I usually just want it to be level in their system. I always start with the short actings to establish tolerance first. And then, yeah, I think the extended release is just a great thing to go to. Clonidine, I like a lot too for the more aggressive kids, as long as they tolerate it with their blood pressure. Clonidine probably works a little better. And they have a patch, but they don't have an extended release. So that you could dose twice a day.
Thank you, Dr. Campbell. We appreciate your expertise and your time, and we'll stay on. If anyone submits a question moving forward, we can either email Dr. Campbell if she has to leave, or we can come back to it at the end after the case presentation.
I'll pay attention to the chat box as well.
I appreciate that. Thank you. But in the chat, we're going to go ahead and put the link to the survey for folks to get credit for attending for CEUs. Our next session will be August 13th. And the topic is mood disorders and risk assessment with adolescents, when Ashley is coming in to save us again. She's going to be presenting, and we do need, we have case opportunities for people to present their cases. So please just reach out to us. Let us know. We send out and ask people to present cases for us. But thank you so much for your attendance. We'll stay on for a few moments if anyone else wants to stay on, but have a good rest of your day.